Hello, welcome to my channel. My name is Michelle. So in today's video, we'll discuss Macrosomia. So we're discussing big babies. Yeah, I'm sure you have seen, for example, in this picture, I've seen some big babies on TikTok. I've seen big babies. So we're going to discuss how these babies get this big and what happens when they get this big, the complications that they may have, and briefly how to manage these complications. So, what is Macrosomia? So, Macrosomia simply means a birth weight of a newborn of more than 4 kg, irrespective of the gestation age. So, sometimes, because the baby has been in the mother's womb for a long time, let's say 48 weeks, 50 weeks, the baby is still growing. So the baby will be large or way more kgs. But that doesn't matter in this definition, because the main focus in this definition is the weight, which is more than 4 kg. So this microsome is very common in mothers who are diabetic. So from this lecture, we see how this comes about. Of course, the other factors that contribute, like the genetics of the parents, all these may contribute to the weight of the baby. So there are a few things that you need to know about these babies. So they tend to have excessive body fats. So they have increase in body fats and increase in muscle mass and organomegaly. So they are going to have large organs, large body mass, and body fats. But their brain size does not increase. We move on to risk factors. So what will cause or put this fetus at risk of becoming Macrosomia? So one of them is maternal age. So usually mothers that are above 30 years old may tend to have kids with Macrosomia. Multiparity. So you have mothers that have given birth several times. Then you have gestational age. Of course, the older the baby is in the mother's womb, the more it grows. So an history of previous Macrosomia. So this mother had a child also was weighing more than 4 kg. The current child is also likely to weigh more than 4 kg. Race. For example, Africans tend to have larger babies or Macrosomia babies. Male sex, family traits. Some of these big babies, it's due to genetics. As I mentioned earlier, both parents are huge. So they are likely to have babies that are huge or big and weigh more than 4 kg. And also weight gain during pregnancy. Because remember, the more the mother eats, the more the baby eats. So the more the baby eats, the larger the baby grows. So this can also affect the baby. And of course, diabetes. So we have mothers that already have diabetes, as pre-existing diabetes, or gestational diabetes. So this is a mother that was not diabetic before she was pregnant. But as soon as she gets pregnant, she's diagnosed with diabetes. So these are the risk factors that contribute to Macrosomia. Okay, the pathogenesis. So let's view it in this way. The mother and the fetus is exchange of substances. And one of the major substances that exchange is glucose. So, in maternal diabetes, mothers that are diabetic have poor control of their blood sugars, or even mothers that are not diabetic, but they develop gestational diabetes. What happens is that they have increase in blood sugars. So this increase in blood sugars, they pass through the placenta into the fetus bloodstream. So the fetus blood sugar also increases. Because of this increase in blood sugar, the pancreas releases insulin to reduce the blood sugars in the fetus bloodstream. But because of excess sugar, because the source of the sugar is poorly controlled, so the mother has excess sugar, which is transmitted to the fetus, is also in excess. So when the fetus produces the insulin, it flows to reduce the blood sugar to the normal levels. So what happens with time is that the pancreatic cells become hyperplased. As a result, they start producing enough insulin to counter the sugar. But this production is so high that the moment you withdraw the supply of sugar, the fetus will go into hypoglycemia. But since the fetus is still in the mother's womb, the supply of this high glucose is still there. Even if these beta cells that have undergone hyperplasia produce high insulin, it will still counter the high glucose. So during this period, the sugar and the insulin balance. So now, as the fetus is still in the mother's womb, this sugar, which is well controlled in the fetus, is now absorbed by cells to be used for growth. So now remember, there's high supply. Then this high supply goes into the bloodstream of the fetus. The fetus is able to absorb these glucose into their cells for energy and growth. As a result, you have a Macrosomia baby. But as soon as the child is born and the placenta and the umbilical cord is cut, that disconnection from a high source of sugars to no sugar keeps the baby into hypoglycemia. Because remember, the beta cells are producing high insulin to counter the high sugars. But now you have cut the sugar and there's still high insulin. So the baby is easily tip into hypoglycemia. So one of the things that you need to do when these childs are brought to the world, when they are delivered, is to put them on glucose. You start feeding the baby as soon as possible. If you are not able to feed the baby, you can put them on glucose, dextrose. I'll show you a quick way of how you can manage that. So this is how a pathophysiology is. So on the investigations, you would want to check the blood sugars. So you check the blood glucose. Then you would also want to do a full blood count to check for polycythemia. Then serum electrolytes, especially calcium. So you check if the babies are hypocalcemic. Then check the bilirubin levels for jaundice. Then also do some ultrasound. Chest, abdomen, and also aid ultrasounds to check for birth injuries, fractures, and internal bleeding. Then also do some monitoring of the heart and body temperature. And of course, So now that this baby, you have seen that this baby is Macrosomia, they tend to have complications. And these complications, the first major complication that they will develop is under metabolic complications would be hypoglycemia. So these babies would be hypoglycemic very quickly after delivery. Then the other one will be hypocalcemic, you have hypophosphatemia, you have iron metabolism abnormalities. Then under respiratory complications, you may have respiratory distress syndrome. They may also have TTN, transit. And under respiratory, they may have respiratory distress syndrome. This may be due to poor surfactant production. Then they may also have transit. So under respiratory, they may have respiratory distress syndrome. This can be due to poor production of surfactant. Then they may also have transit tachypnea of newborn. This usually resolves within 24 hours. Then under hematological complications, they may have polycythemia, thrombocytopenia, jaundice. These children may also develop jaundice. They may have hyperbilirubinemia. Then under cardiovascular, they may have cardiomegaly. Remember that because of increased supply of those sugars, the babies is able to utilize them, hence they have increased growth in their organs. But the brain is usually not affected. The size is relatively normal. Then under the central nervous system, they can have neural tube defects. So here are some of the examples of these neural tube defects that they may have. They may have some spinal bifida. Other complications that they may have are birth injuries. Remember, these babies are very big, and the birth canal usually dilates up to 10 centimeters. So when this baby is bigger than this passage, the baby may have injuries. So the baby may have a brachial plexus injury. They may have cervical or humeral fracture. So they may fracture their hands. They may have visceral hematomas, such as so they may other complications that they may have are birth injuries. So during antenatal, when you measure using ultrasound, the approximate baby weight of this fetus, you may discover that the baby is most likely to be over 4 kgs. So you have to put up other measures of delivery. For example, you may want to put this mother on a list of cesarean sections, because ultrasound is usually not accurate. So they may measure that this baby is approximately weighing 4 kg. Only the mother to deliver the baby, and the baby is less than 4 kgs. But once the ultrasound states that this baby is likely to be more than 4 kg, you need to make sure that you put up other measures of delivery. So one of the birth injuries that is Macrosome babies can have is injury to the brachial plexus. They may fracture their clavicle. They may also have a cephalohematoma. So here's a picture. So this is where blood collects between the so they may have cephalohematoma as one of the complications. So this is where blood accumulates between the baby's scalp and the skull. I'll show you a picture. Then they may also have internal bleedings, because remember this baby is big and it's passing through a narrow birth canal. So this may injure the baby's kidneys, the spleen, and cause the hemorrhage. So this is why most of Macrosomia babies, once ultrasound states that this is a 4 kg plus baby, you would want to do a cesarean section to avoid these birth injuries. So management, remember these babies are usually hypoglycemic. So you may give dextrose 10% or feed as soon as possible. Then they may also be hypocalcemic. So you may give them calcium gluconate and make sure you monitor their heart rhythm. Then if the child has respiratory distress syndrome, O2 and surfactant. Then if the child has polycythemia, you hydrate, or you do a partial exchange transfusion. If the child has hyperbilirubinemia, the baby has jaundice, the baby is jaundiced, can do phototherapy. So this is where Macrosomia ends. It's a short video. Thank you for watching.